without wasting any more time. So the topic which has been allotted to me is approach to neonatal jaundice, diagnosis and algorithmic management. So as we all know, jaundice in neonates is very common, which is usually indirect hyperbilirubinemia. And we should investigate jaundice when it starts very early in the life, like I will say day 1 or day 2. It's prolonged, it's new onset, like a baby was discharged from the NICU, then again came up with the jaundice, or the jaundice is at very high levels. So the purpose of evaluation at this stage is to find potentially life-threatening causes and to find if urgent therapeutic, major cohort is found by unconjugated hyperbilirubinemia, which is mostly physiological or breast milk jaundice. A small cohort is found by blood group incompatibilities, hemolytic anemia, and Crigler-Najjar syndrome, and some other rare disorders. So when jaundice is persisting beyond 14 days, or even if earlier in NICU or on examination we find that persistent high color urine is there, we need to rule out cholestasis. So at this stage, we should get both unconjugated and conjugated fraction of bilirubin. If we look at the definition, so prolonged elevation of conjugated bilirubin beyond 14 days of life. So previously what we used to tell, if bilirubin is less than 5, then conjugated more than 1, or bilirubin more than 5, conjugated fraction more than 20%. But now most of the authorities and even ISPGAN, NASPGAN guidelines suggest that if direct bilirubin is more than 1 milligram per deciliter at any point of time beyond 2 weeks of life, we should take it as neonatal cholestasis and we should work up accordingly. The incidence of neonatal cholestasis is 1 in 2,500 term infants. So the one question is, from where this 2-week thing is coming everywhere. So normally breast milk jaundice is a very common entity which is present in 10 to 20% of all the babies. So that is around 200 or 300 times more common than neonatal cholestasis. So this 2-week thing has come to overtly work up these babies who are having physiological breast milk jaundice. If we look at the etiology, then conjugated jaundice is a common sign of more than 100 disorders, and these number of diseases are increasing every month and year. If we look at grossly, first are anatomic obstruction, infections, toxins, and nutrition related like total parenteral nutrition, endocrine causes, immune related causes, then other miscellaneous causes like neonatal hepatitis, hypoxia, ischemia, HLH, and rarely malignancy. Then this group of disorders, these genetic and errors of metabolism, they are having a huge list. These underlined one are the common. I will not go into details of, or I will not be reading the list now. But these are the disorders which are increasing, and next generation sequencing is helping us to find more and more about them. So if we look at the etiological spectrum over the years, so biliary atresia is almost static in almost all series between 25 to 45% of the patients. Idiopathic neonatal hepatitis, what we used to use the word previously, now we use transient neonatal cholestasis. That is decreasing, and that is mainly because of the monogenic diseases which are rising. And now the series have says that where diagnosis could not be made and genetic test was done, around 25% came out to be monogenic diseases. Then this is another interesting cohort, this prematurity, TPN, and sepsis. So as a pediatric gastroenterologist, whenever we are called in an ICU for complaint of jaundice, what we see that there is a new group of these patients because of the very good NICU facilities, even second and third tier of cities in India. What we say, for 26, 28 weeker babies are also surviving. They are having prolonged NICU stays, sepsis, prematurity, TPN. So they are having jaundice. So we have to be very careful while dealing with these babies because they can have the other diseases also, but they have other predisposing factors at the same time. So if we look at a particular case of a neonatal cholestasis, we can have 3 possibilities. Either in an ICU, we are seeing already admitted child who did not have jaundice. There can be prematurity, TPN, sepsis, or small for gestational age. Next group is sick neonates who come to us in OPD or in emergency rooms with decompensated liver disease, so it is not difficult to identify them. The third and difficult component is non-sick neonates who are appearing well but are having jaundice. So as I said, these NICU babies can have both these components, so we need to be careful while assessing them. So first thing is to suspect as early as possible. So the question is why we need to suspect so as early as possible. The first condition is biliary atresia. As we are seeing with the recent publications that as early we do surgery, even 30 days, 45 days, the results will be better. So time is ticking if it's biliary atresia. We can't waste any day. Second is metabolic diseases, which are life-threatening but potentially treatable. If we start treatment early, say life can be saved. And the third, an important cohort is the patients where diseases are potentially untreatable, but making a diagnosis is very important for antenatal diagnosis of future pregnancies, like many of the mitochondrial DNA disorders that we are seeing. So in this situation, role of pediatricians, neonatologists and primary care givers becomes very important to identify early. So the second thing is how can we detect them early? So in a sick neonate, I will say again, detection is easy, further management may be difficult. You admit and you start workup and start management. In non-sick neonates, first we need to ask and confirm the urine color. As I said, even if earlier urine color is persistently high, that is the first and foremost clue for neonatal cholestasis. A simple thing is to palpate abdomen. If we just palpate it, if baby allows or if he is sleeping, if you get a big liver or a spleen, that means something is not going right because history may not be always very reliable at this stage. And the third and important part is ask for stool color, where stool card can be utilized. That I will talk in next slide about that. And when should we do all these things in non-sick neonate is at the time of vaccination, just 2-3 simple things can be done as I have said. And if any time jaundice is the presenting complaint, like what I remember in our training days during PG, we remembered like always, any baby who is well thriving with jaundice, it's okay, give time. But I don't think that with increasing knowledge and increasing research, that thing persists anymore. So just a few words about stool card, because that is not being utilized in India or general practice now also. The good data comes from Taiwan, where it was used in 2004, distributed to all the parents and health professionals. That contained 3 normal stools and 3 clay color stool colors. And screening program was started to detect early biliary atresia. So what they have found that the children who were operated at less than 60 days, and success of Kasai increased significantly. And the 5-year survival also increased significantly in the patients after the use of stool card. So do we have any Indian stool card which is made in Indian indigenous patients? So there is one publication by Yacha sir and team from SGPGI and Lady Harding Medical College, where they have formed a stool chart, color chart for the patients from biliary atresia. So 1 to 4 they have diagnosed as pale, and 5 to 7 were pigmented, and these were all confirmed biliary atresia cases on peroperative cholangiogram. So that is something that can be utilized at least in the primary care centers and vaccination centers and at initial workup in non-sick neonates. So first that we know now, okay, this child is having neonatal cholestasis. Now second important step is to take a detailed history and examination. I will not be going into detail of all these things, but that is definitely very important to get the clue about the etiology, so that we can channelize our investigations later, and we can even give a slight prognostication to the parents also. So all these, I will say, all these questions of in history and clinical examinations are very important, which has to be done diligently. So now how to investigate these patients? Now there is neonatal cholestasis. We have examined the baby. Now we have to see how we need to approach these babies. So first, we know that this is conjugated hyperbilirubinemia. Now get a full LFT along with GGT and INR after 6 to 8 hours of vitamin K. That is very important, which helps us later in diagnosing the patients and understanding the severity. So 2 group of patients normally we find, non-sick neonate and sick neonate. Sick neonates will be in early, there will be gestational alloimmune liver disease, neonatal herpes in first week of life we need to think of. Then galactosemia, tyrosinemia, sepsis, HLH, PFIC, some forms like PFIC2 and BASD, and giant cell hepatitis, autoimmune hemolytic anemia, mitochondrial hepatopathies. These are the sick neonates. The moment we find a decompensated child with a skin bleed or ascites, we need to think about these conditions. Now the second and interesting part comes the non-sick neonate. So what we should do first is to observe stool color and ultrasound abdomen. These two non-invasive basic things we can do. And we can divide these patients into 3 or 4 categories like pale stool and ultrasound suggestive of biliary atresia, pigmented stool pigmented stool with ultrasound suggestive of biliary atresia, then pigmented or pale stool with ultrasound not suggestive of biliary atresia. So I will go one by one on these case scenarios. If it is a pale stool, ultrasound is suggestive of biliary atresia, and clinically and all we are thinking it is going in the direction of biliary atresia. We need to do liver biopsy. If typical findings of liver biopsy of biliary atresia are there, we should go ahead with peroperative cholangiogram and Kasai portoenterostomy. If unfortunately it's a negative POC, then we need to work up for the other possibilities of neonatal cholestasis. If liver biopsy is not suggestive or equivocal, then we can think of looking at GGT, that is GGT is very high, HIDA scan like hepatobiliary scintigraphy, non-excretory, and we are thinking still it is a possibility, we should go ahead with POC without wasting time. In this thing, 2 catch will be there, I will say. If age of the child is more than 60 days, 70 days, 80 days, and at your center turnaround time for liver biopsy is high, like 3 days, 5 days, it is better to directly go to peroperative cholangiogram without wasting any time if suspicion is very high. Now, second thing is if age of the baby is more than 90 or 120 days, then the chances of success of Kasai are low. So we have to take a decision on case by case basis for upfront liver transplant in this group of patients. Now the second and third group, I will say pale stool and ultrasound not suggestive of biliary atresia, and pigmented stool ultrasound suggestive of biliary atresia. These are the confusing cases where we don't know it can be biliary atresia or not. So if stool is pale, I will still say we should go ahead with liver biopsy and follow the previous protocol. But if we are seeing in front of our eyes stool is pigmented, it is better to get a hepatobiliary scintigraphy because chances of ruling out and avoiding the POC will be high. If liver biopsy is equivocal, then again either we can go with peroperative cholangiogram or looking at other factors like nuclear scan or GGT, we can think that it can be any other cause of cholestasis. Then fourth, like pigmented stool and ultrasound not suggestive of biliary atresia, we have to look at, still we have to definitely rule out biliary atresia clinically at least and on liver biopsy if possible. We can look at GGT. If low GGT is there, we can think of a lot of PFICs which are increasing day by day, except PFIC3, bile acid synthetic defect and ARC like arthrogryposis, renal dysfunction and cholestasis syndrome. If liver biopsy is indicated, like rest of all are usually having high GGT. So Alagille syndrome liver biopsy can help if it is done after 3 months of age. Storage disorders it may help, PFIC it may help if IHC is done simultaneously. And in any liver disease to know about the fibrosis and cirrhosis it may help. So once biliary atresia is ruled out, we need to consider genetic analysis early because as I have said, more than 100 diseases are there clinically and on basic test it is difficult to all the time suspect these diseases. Then comes the group of sick neonatal cholestasis. So how can we approach them? If they are presenting in first week of life with liver failure, gestational alloimmune liver disease, neonatal herpes and HLH and sepsis will be the first thing that we will think. If baby is having cataract along with other features of decompensation, galactosemia is a possibility. So urine NGRS as a preliminary test and GALT levels before blood transfusions are important to diagnose these. And then if on palpation of abdomen we are finding nephromegaly and INR is disproportionately high, tyrosinemia is a possibility where alpha fetoprotein and urine succinyl acetone will help. Then if GGT is low and pruritus is there, then PFIC2 and bile acid synthetic disorders we need to think. And bile acid levels may differentiate between these two entities if sent before the start of UDCA therapy. Then if child is having hypotonia or multi-system involvement like nystagmus and other things, then we need to think about mitochondrial hepatopathies and ABG and or lactate levels will be high. If on palpation splenohepatomegaly is there, these are very simple things but they help us a lot in getting at least a differential diagnosis before starting the workup. If spleen is huge, we need to think about Niemann-Pick C, which is a relatively common cause of neonatal cholestasis. These babies may not be sick always and many of the times jaundice resolves over time, but later in the life they will develop neurological problems. Then comes if child is very sick with vomiting, diarrhea, severe failure to thrive, we have to think about Wolman disease. Again, this is a rare disorder. And if there is disproportionate anemia and we can find hemolysis happening, DCT is positive, we need to think about DCT, giant cell hepatitis, autoimmune hemolytic anemia. So these are just a small group of disorders. And again, I will say, whenever genetic analysis, genetic analysis should be performed at earliest whenever indicated and diagnosis is not clear, because it will take 4 weeks time, like normally what it is taking, I don't know if it is earlier in other centers. So that is the time, if we send early, by the time we are finishing the workup and doing the preliminary things, we will get the proper diagnosis. So just these are the tier-wise investigations in a sick child. So first LFT with GGT and INR. Second step, to rule out treatable causes like galactosemia and tyrosinemia before any other disease. If sepsis is suspected, do a sepsis workup. If low GGT, send bile acid levels before starting UDCA. Then next year I will say blood gas analysis, amino acid levels, urine organic amino acid levels for citrin deficiency, organic acids, acyl carnitine profile, fatty acid levels, fat chloride and echocardiography. These will form the next step of test. But always the clinical judgment and the preliminary test will help us in deciding all this. Liver biopsy, bone marrow biopsy may help in a few cases. And genetic analysis, as I said, in this era we should try to do it early when we are not clear about diagnosis. Just 2 slides about biliary atresia, because the early is about, as I said, biliary atresia is very important. One question which comes in our mind is how late is too late? Like how much time can we buy in diagnosing these kids? So I will just put this slide that is mainly formed from the study from the Japanese registry. So biliary atresia patients, if we are going to operate beyond 90 days or 100 days, success of Kasai is less, around 20 to 30%. If we operate them before 60 days, then the success of Kasai is 60 to 80%, and more than 60 days, it is around 60%. Now, one interesting part is, if we divide these less than 60 days patients before 30 days and after 30 days, now we look at the patients who were operated before 30 days. So successful Kasai was 70 to 100%, and 30-year native liver survival was 75%. I will say that is a very encouraging thing, and that is something is in our hand to detect these patients early. So we should put all the efforts to find these patients early. So fortunately, in last 3 months, we have done 2 Kasai surgeries as 25 and 28 days. We have done liver biopsy at 12 days and 30 days and 13 days, and there were typical features of biliary atresia even at that age. Of course, the clinical examination showing firm liver will help us in knowing that how the liver is. And the second thing after biliary atresia that I will try to emphasize is the genetic analysis. Once biliary atresia is ruled out, it should be considered early in the course of disease. Over last 3 years in my center, I will not say that it is a big pediatric hepatology or gastroenterology center. We have found 11 rare patients, Niemann-Pick type C 6 patients, mitochondrial DNA depletion syndrome 3 patients, PFIC 7. I didn't know that it exists, but after the report I saw that PFIC 7 is also there. And DC2 mutation, which is neonatal sclerosing cholangitis. And we have just showed this poster in UEG Week Vienna in 2022 regarding 4 of these patients were initially mimicking like biliary atresia, but there are some subtle clinical findings which are not going in favor. So rather than going with POC, we did liver biopsy and everything and genetic analysis, and we found that 2 of them had Niemann-Pick type C and 2 of them had mitochondrial DNA depletion syndromes. So in management, I will just show this one slide for that. Early surgery for biliary atresia and choledochal cyst. Find treatable causes and treat early like for metabolic causes, galactosemia, tyrosinemia and bile acid synthetic disorders where oral cholic acid we can give. Then third year, which is common to most of the patients. Drugs which promote bile flow, vitamin supplementation, nutrition, MCT oil, that is for all chronic cholestasis cases, and try to finish immunization before transplant is needed. So nutrition, immunization are very important before we are going to take up the child for transplant. And then surgical interruption of bile acid enterohepatic circulation is helpful, like internal and external biliary diversion and ileal exclusion for some of the diseases. Then of course liver transplant and genetic counseling in untreatable genetic diseases. So these are just 2 messages from Dr. Yacha, who sent me multiple slides, but I could add 2. What he wants to tell everyone, that we need to change from road rollers pace to fire brigade pace. We cannot waste any more time. We can't say that child is healthy and having jaundice, it's okay. It's not okay at all. We need to find the etiology. As I said, this transient neonatal hepatitis or INH is decreasing. We need to find the etiology as early as possible and with as much confirmation we can do. And the second thing, what he said, that just a message again from sir only, to recognize all entities of NC. This INH is decreasing. We should not keep it even in our differential diagnosis until we have exhausted all our workup and we find that, okay, probably the jaundice is increasing. So we need to act correctly and act meaningfully. Thank you everyone for the patient hearing.